Welcome to our noontime webinar. I am Dr. Jill Brooks, Senior Director of Education for First Healthcare Compliance. At First Healthcare Compliance, we help you with a comprehensive compliance management solution tailored to your business, a hospital network, healthcare practice of any size, billing company, or skilled nursing facility. As part of our complimentary educational webinar series, we bring you experts from around the country to discuss relevant topics in the healthcare industry. Today, we are so pleased to have our coding expert back with us today, Karna Morrow, the manager of the consulting team at Coding Strategies, our valued partner. Karna's areas of expertise include billing and collections, coding and compliance, revenue enhancement, and process improvement with medical billing firms, community and academic hospitals, as well as private practices. Karna holds a Bachelor of Science degree from Weber State University. She also holds the professional certification of Certified Professional Coder, Radiology Certified Coder, and Certified Coding Specialist. She's also a HEMA-approved ICD-10 CM trainer. Karna is an active member of the Radiology Billing Management Association, serving on the Coding Subcommittee and on the Educational Materials and Products Committee. She's also a frequent contributor of coding and compliance articles to the Oncology Practice Management publication. A copy of her handout is available for download on the control panel. Feel free to submit questions during the presentation into the question box on your control panel. Your Paycom CEU certificate will be emailed to you from Paycom within 48 hours following the broadcast. There's no need to request it. Additional CEU opportunities will be available to BC Advantage members following the live broadcast. See their website for details. Okay, Karna, go ahead.
Good morning. Thanks, Jill, for that introduction, and welcome everyone to our annual presentation of the code changes. This is, becoming almost expected. Once upon a time there were a couple changes here and there, but I think we're getting used to there being quite a volume of changes, and this year is really no exception. As we go through, Coding Strategies is very happy to participate with First Healthcare and present this material. We appreciate your respect to the copyright of the material, and if you do need it in a different manner, please reach out to one of us and we'll be happy to accommodate that. This year's agenda, it might be a little misleading. There are just 3 primary objectives. The only thing we need to do in the next hour is explore the changes. As we do that, please think about, is this going to change any documentation? What changes do I need to make my providers aware of, and which ones are more just a coding change? And then we need to, obviously, we can't forget the guidelines. As straightforward as that is, we do have to sort of manage expectations, and we are not going to go through each and every one of the 422 changes in the CPT book this year. What I want to do, and what I hope your takeaway is, which of those additions are relevant to you. And so if you'll have a piece of paper, we used to call them the parking lot issues when we're in group meetings, and just take note. These topics are going to require a deeper dive, or these topics are going to require additional information. I'm sure that we have all just flipped through our CPT book, and as we've gone page by page, all of those little triangles, whether yours are green or whether yours are blue, I think they were a little overwhelming. I think I started looking for the ICD-10 code for code book hypertension. What I need you to do, though, is always keep things in perspective. We can't, the sky is not falling, Chicken Little is not crying. Almost all of the 422 revisions that have been, the discussion of a lot of advertisement, they're all related to one change. Moderate sedation changed for 2017. Because moderate sedation is inherently related to the majority of the surgery codes or the majority of procedures, then one change impacted 420 plus procedures, not 420 individual changes. And that, I think we can all get our head around. But don't forget that it's not all about the codes. I do need you to keep in mind that there are multiple resources that must be reviewed to ensure that you're actually applying codes correctly. And by that, first thing what we want to talk about is the NCCI edits. The NCCI edits, the edit themselves are probably inherently uploaded into your scrubber, your claims manager, your clearinghouse. but the policy manual is something that you need to download. It's free. Google NCCI Policy Manual. Remember that it is germane to CMS. Now, that does not mean other payers may not follow suit, but if you run into situations where the policy manual may contradict CPT, the policy manual trumps for CMS. Each year there are minor changes, and this year is no exception, and I want to highlight just one example. The bottom of your screen shows what the guidelines said in 2016. If I performed, let me say I did a limited abdominal ultrasound, and from that ultrasound, from that diagnostic ultrasound, I determined the need to do a biopsy, or I determined the need to do an aspiration. In 2016, if you read right in the middle, it says both the diagnostic ultrasound and the ultrasound-guided procedure may be reported separately. Now look at it for 2017. If the diagnostic imaging led to the decision to perform, and they are at the same or different patient encounters on the same date of service, they are now third line down, not separately reportable. That is a significant change for CMS claims for 2017, effective Jan 1, and it's an example of what we would not know if we did not look at this additional resource. This is not something that may be programmed into the edits automatically. Remember that the edits are updated quarterly, and so they may or may not be in sync with the guidelines that are written in the policy manual that comes out in November. So just keep that on your radar as we go through. When you look at the actual CPT book, we all know that the dark circles are new codes. We've already talked about how the triangles are changed codes. Well, there's two symbols to keep in mind for 2017. As we've already mentioned, there are changes to the moderate sedation. So it makes sense that there is no bullseye for 2017. They're gone. And so that means that moderate sedation is no longer inherently included in those procedure codes. A new icon for 2017 is actually a star. And the star has been added to very specific codes. If you start flipping through your CPT book, start in the E&M section. You'll see them predominantly through there. The star is identifying services that can be used through telemedicine. And that is an evolving way to practice, to interact with our patients, to provide care, to be able to provide more specialized care in rural or underserved areas, and so they're recognizing that. If they're identifying services specifically for telemedicine, then it makes total sense that we have a new modifier. Modifier 95 will be used for any of those codes that are tagged with a star that you have provided using real-time interactive audio and video. That's key. Whatever service you're using has to have both components. It has to equal what would have happened in a face-to-face encounter. It is still between the patient, the physician, or other qualified healthcare professional. As expected, CMS has added some of their own guidelines and their own scope of use, specifically for 2017. The second bullet is very important. If you have those ESRD or the advanced care planning codes on your radar, Medicare is adopting a new place of service code, and it will be 02 for telehealth, and that is for all services after January 1 of 2017. Not all of the changes that we experience on an annual basis really impact the documentation as much as they do the guidelines. So before we get too far in, I do want to just sort of offer a reminder. This is specifically to the Category 3 codes, which we'll get to towards the end. The foundation of coding is pretty simple. Code to the highest degree of known specificity. Well, if there's a Category 3 code for an emerging technology, that means I can't use an unlisted procedure code anymore. Even if that Category 3 code is not covered, I still need to use it to report appropriately. The other thing, while we're talking about what extra resources you need to consider, pay attention to the last bullet. Category 3 codes are released semi-annually. And so an unlisted procedure code in June may have been replaced with a Category 3 code in August. So somewhere in July, we need to keep this on our radar, that we will continue to look for specific updates. Subtle changes happen every year in the book, and the point of these subtle changes is simply to ensure consistency in nomenclature across code sets. It's not going to change how we code. Second and subsequent veins means basically the same thing as subsequent veins. So even after we take away the moderate sedation, not all of the changes will impact us dramatically. There were subtle changes within the guidelines for pediatric critical care. 2016, the guidelines said these codes are only to be reported, whereas in 17 it now says these codes may be reported. There were changes, while I'm there were changes within pediatric critical care, if that is your primary focus or your service line. There were distinct differences between pediatric critical care and neonatal critical care. And so the guidelines have been revised to sort of make those more uniform. I mean, after all, you're basically, your target audience is the same, and so they felt that the guidelines should be a little more consistent, and so that's one of the changes for 2017. It also really highlights the need to make sure that you do read the guidelines. I know this is, 'tis the season that we don't read guidelines. We just put it together based on the picture on the box, hope we don't have extra screws. Yeah, let's not try that with the CPT book. Guidelines, the nomenclature is changed frequently to match the technology or the technique that we're using. So if a certain decompression procedure is no longer frequently used with the endoscope, then that language has been removed from the code. Similarly, that phrase has been changed within another range of codes. And again, this is not something that necessarily impacts our coding. It just is matching the codes and the descriptions with clinical care practices. In 2016, OCT, the optical coherence tomography, had its own code. And in 2017, it finally grew up and became a real code, as we like to say. It moved away from a temporary. But instead of giving it its own code, what the AMA decided to do was to bundle that technique into an existing code for IVUS. And so when they evaluated the work, the skill, the risk, the practice expense for both of those imaging techniques, they felt it was appropriate to put them both in the same code. 92978 then will be used for IVUS or OCT, in addition to whatever procedure that they used it for, and it is still per vessel, and that's an important piece of dictation to make sure that those vessels are clearly identified. The change here was interesting. Fluoroscopic guidance, I think, has always been billed as an add-on code. I don't know that any of us have used that as a standalone code, but perhaps some claim scrubbers occasionally let one go through. So the only change there is simply to emphasize that if it's an add-on code, it is listed separately in addition to the code for the primary procedure. The unsaid with that is, if you think about the concept of an add-on code, that means there's a base code. Well, in the coding, in the code set, then those base codes and add-on codes are carefully matched within a payer's computer. And if we try to give it an add-on code with an unrelated base code, I mean, if I tried to bill that fluoro code with an E&M, there's no way that claim's getting out the door. That's not an appropriate add-on code for that base code. So it is interesting how they have changed some of the notes following those codes, that if imaging guidance is performed, see these image guidance codes for these procedures. And they're really tightening up what base codes go with which add-on codes. Doesn't change documentation, but it may in fact change how we report certain services. There are a lot of examples of this type of information throughout the book. A lot of new notes. Don't report this with this. This is an add-on code for this. And so again, reemphasizing, please read the instructions. Don't just rely on your vendor to change out old codes to new codes. What's the application of that? And there's quite a few of them as you go through this version of the CPT book. It is also very important every year to remember to continue to bookmark the AMA CPT errata page. Any changes, any technical corrections, it's usually about through Q1 that they continue to post them on that website, and then beginning Q2 it gets switched over to the CPT assistant for any of those updates. Okay, as we start to jump into the codebook itself, then I just want to remind you, pharmaceuticals, all of your HIC picks, we will need to go through those and make sure not just the codes, but make sure the doses are still consistent, 16/17. We want to focus on the procedure codes in this limited time that we have, so I'm not going to specifically cover them, but it's here as a reminder that you want to go out and review those. The CPT book starts with the E&M, and so that's where we're going to start. And believe it or not, there's only one primary change. What they've done is taken the 99420, which was in the E&M section as our health risk assessment, and deleted the 99420 and replaced it in the medicine section with two new codes, 96160, 96161. The interesting thing about this is really 96161, administration of a caregiver risk assessment for the benefit of the patient. And I'm sure there's many of you who do spend a considerable amount of time with, say, the spouse, with the parent, with the siblings, hoping and helping them manage the patient's conditions. And so if you are doing any risk assessments, depression inventories for the caregiver in relationship to the patient, these are two codes that you may want to explore a little bit further. As we move on to surgery, obviously we know that the primary target is that moderate sedation. There's another guideline change that I just need to put out there. It may not affect everyone, but if you happen to be in Florida, Kentucky, Louisiana, Nevada, New Jersey, North Dakota, Ohio, Oregon, Rhode Island, then this does pertain to you. We've known for a long time that Medicare has wanted to eliminate the global surgery package. This whole concept of putting in a pacemaker and having a 90-day follow-up, or doing fracture care and having a 10-day follow-up. The challenge is that procedure code inherently includes a certain amount of work for those follow-up visits. Okay, but what if the person doing the follow-up isn't the person that did the procedure? What if the number of follow-up visits was relevant in 2000, but changes in practice patterns no longer make that number of visits relevant in 2017? So Medicare is circling back to the table, and for groups, so if your practice has more than 10 providers, and you are in one of those states, then you really need to be watching your Medicare guide, your Medicare bulletins, because starting July 1st, they are going to ask you to literally submit on the claim the post-op visit. 99024 has been around for decades. A lot of us use it internally, more as just like a tracking device, but Medicare wants it on the claim. Yes, it will still be a zero charge, but what it is going to allow Medicare to do is to start gathering data. How many post-operative visits are accurate, are reasonably being performed with a given surgery in 2017? Now, anyone in any state can begin reporting those to Medicare in January, and that allows you and your practice to participate in this data collection. We can all anticipate what will happen in a couple of years with this data as they start reevaluating the RVUs of the codes and which may need to be adjusted based on historical expectations for follow-up care versus the current reality for follow-up care. One other piece that came out of this same newsletter was a sort of highlight on 0-day global services. Now, all of you who are in sort of the clinic setting or private practice setting, I'm sure you do a lot of minor surgical procedures. I want you to think about injections, think about aspirations, debridements, even simple lacerations. A lot of those have 0 global days. The myth is that if there are 0 global days, there is no package. And that's not accurate. Even a 0-day surgical code inherently includes a certain amount of history, exam, clearance, risk factors. And so that brings up modifier 25. This slide and this information reminds us that modifier 25 is still on Medicare's radar. And when they identified 83 specific codes that were billed over half of the time within E&M that was not justified, that has them scrutinizing our services even more. As we move into 2017, every compliance plan has a risk assessment. This should be part of your risk assessment for 2017. You do need to audit those minor surgical procedures, and not just that an evaluation was done, but is it above and beyond what is expected for that procedure? As part of this, Medicare has identified this very specific list that are under tighter scrutiny. And as you scan that list, just because nothing you do is specifically on there, it does not mean that it's not worth taking a second look at some of the things that we do with a modifier 25. There are 3 new segmental spinal instrumentation codes, 22853, 5459, very specifically for a biomechanical device. 2 additional codes in this same section highlight a continuing trend, that is to bundle imaging guidance if the procedure is frequently done with that. There's also those 2 magic words, when performed. If you insert this device with guidance, here's your code. If you did not use guidance, this is still your code, and it would remain unmodified. There's new codes for pelvic ring fractures, 27197, 27198, very specifically being able to trend and track not only necessarily the types, but the volumes, and what certain diagnosis, what's the frequency, how often is this happening. It is interesting that we are told for a closed treatment, if it's only the anterior ring, that we are to use an E&M. Another example of where the guidelines are very important. Having a coding system, whether, whatever online system you're using, and I'm definitely not trying to promote a specific vendor or advertise for a specific vendor, but whether it's an encoder or 3M or Quantum, whoever it is, sometimes you still need the book. And these new codes, 28291 and 28295, are a good example of that. I did not copy it out of the CPT book, but if you are performing these types of procedures, the AMA has created 2 complete pages of illustrations to specifically illustrate that 28291 is for this specific joint with this specific type of correction. That helps ensure, obviously, compliance. But the unsaid message with the AMA taking the time to illustrate out a block of, I think there's 9 CPT codes, we might not have gotten it exactly right in the past. And so, again, good opportunity to circle back on what you're doing. The AMA continually tries to over-communicate the extent and the expectations of the codes. So throughout that surgery section, especially the scopes, laryngoscopies, endoscopies, through that whole range, there are a lot of new guidelines that are specifically just definitions. Now, these definitions are very useful, obviously, to the coder, obviously to the physician documenting, but more importantly, sometimes the payer might have a tendency to misinterpret the codes. So if they are considering paired structures to be bilateral, for example, in this situation, then the written guidelines from the AMA to say no, all paired structures are considered unilateral, then that is good information when you're appealing a claim. Sometimes when we appeal claims, we really need to go above and beyond just a copy of our medical record. Remember that a lot of the codes that are created are out of sequence. And so if you look at the new code, the 31580 is retained for 2017, but the indented procedure is completely out of sequence, 31551. It is a welcome change to see more pediatric codes, to see them very specific based on age, recognizing the difficulty of working with much smaller anatomy. As I mentioned throughout the scope section, they're adding a lot of different techniques, whether it's with ablation, whether it's with an injection, whether it's the injection that's specifically for augmentation. As clinical practice changes, then the codes are best updated to support that. Very specific new codes for the respiratory, 31591 and 31592. Now, the reason I've got the notes written the way they are, obviously there's more in the CPT book. Do not report the graft if. Do not report the advancement if. When we have situations like this where a decision tree, code or don't code, is directly hinged on how the procedure is performed, then we really need to communicate this with the providers. Providers are very focused on the procedure, but not necessarily step 1 to step 2 to step 3. But if that's the decision between reporting a graft separately is because it was through a separate incision or through the same incision or through a resection, then those are details that providers need to know. So this is one example of how it impacts documentation in addition to how it might impact your coding. The percutaneous closure of a left atrial appendage is another example of a code that grew up in 2017. Prior it was a Category 3 code, and so now it has Category 1. That is beneficial in a lot of ways. Category 3 codes are frequently considered investigational, and so some private insurance companies will not recognize them. We submit reports. We jump through a lot of hoops to try to get these claims processed. But once they grow up and become a Category 1 code, then it's an established code. There are established RVUs, and it's a lot simpler to get these claims processed. Just remember, with any new code, there are going to be new guidelines. I specifically wanted to pull out this transfusion code, not because the partial exchange is done every day in every office, but I wanted to highlight the 3 words that I have in red. Throughout the CPT book, there are multiple situations, there's even one on a venipuncture, where the phrase necessitating the skill is inherently included in the description. When we see that, we need to make sure that the documentation not only confirms that it was done, but why a physician or other qualified healthcare professional needed to perform that procedure. It's inherent then that it's traditionally done by hospital staff and would not be reported by a physician or by a provider. So it's not enough to just document the procedure. We have to over-communicate the medical necessity of that individual procedure. There are new guidelines for the venous sclerotherapy. I think sclerotherapy is another section that gets tweaked just a little bit every year. And it's really trying to define when we use certain codes and when we do not use certain codes. If these are being done in an office setting, then we do not bill the supplies, we do not bill any of the equipment separate. Even though there are HCPCS codes for, well, still just about everything from sterile trays to the needles to tubing, but none of them are reported separately for these services in an office setting. The expense of that is inherently already built in to the procedure itself. Endovasous ablation, this is a new service, again, for 2017, and the distinction here is that you're actually using 2 techniques for the same procedure. It is a mechanical and a chemical. You are using a mechanical device and then you're infusing specific medication. If for whatever reason you are doing this endovascular therapy, but you're not using both techniques, then you need to use an unlisted procedure code. We would not put a 52 on it to say that we had not met the full intent, because the full intent, or even the base foundation of this code, is for that dual approach. Just giving an example again of some of the guidelines they are getting, the AMA is getting very specific. What is included, what is not included. The mechanical component must be inside the vein, not outside the vein. Just a lot of details, a lot of additional information from the AMA to help us report these services appropriately. The new codes may not be reported in the same surgical field as quite a few things, including the diagnostic duplex study. So if I'm doing a diagnostic duplex of that same extremity during the same encounter, then that imaging is going to be inherently included in the procedure. And that's where we go back to the NCCI of a diagnostic leading to a procedure. Probably, in addition to moderate sedation, the most advertised change for 2017 is definitely with the dialysis access codes. 36147, 36148, for those fistulograms, we have had those memorized for decades. Being consistent with other similar interventions. If you think about how they revised the lower extremity revascularization codes a few years back, and they built those codes on sort of a hierarchy. If the only thing you do is image, then that's sort of the foundation. But if you image and do an angioplasty, the imaging then is built into the angioplasty. So it's a hierarchy. And the more intensive the service, the lower services are inherently bundled. That is what's happened for 2017 with the dialysis codes. The general description for each of the codes within this range is rather lengthy. It includes introduction of a needle or a catheter. It includes the diagnostic angio. It includes all direct punctures, all necessary imaging, fluoro guidance, RSNI, the whole package. So as we go to the add-on codes, then the add-on is simply whether or not it is the stent or whether it is the angioplasty, but all of the base work is inherently included. In 2016, we had a distinct code for the imaging of a dialysis circuit through an existing access. We do not have that option in 2017. So it is one situation where you're going to need to use the same base code 36901, but add a modifier of 52. Again, my decision tree. If I choose code 1 versus code 2 based on existing access or not, then that clearly is part of what needs to be documented. Fortunately, what they did not change was our language. We still have two segments. We still have a peripheral segment, we still have a central segment. The peripheral segment is still defined as exactly the same as it has been historically, and the central dialysis segment is still focused on those three regions, the subclavian vein, innominate, and the SVC. Basically, in my mind, and remember I don't have the clinical background, I sort of draw this imaginary line. And everything above the line is a central segment, everything below the line is peripheral. And that helps me to know whether I'm managing one segment or two. There are add-on codes, so if I've done more than a thrombectomy, a stent, or an angioplasty, if I have an opportunity and a reason to be doing an embolization within that dialysis circuit, then there is the add-on code 36909. These changes, creating new codes and bundling the angioplasty into the dialysis circuit maintenance codes, required some changes in others. There's sort of a domino effect. You change this code, then any other related code might need to be updated as well. We see that happening here with 37246 through 37249. These are new codes for 2017, and they are specifically written for not dialysis, not pulmonary, not coronary, not intracranial, and not occlusive lower extremities. So if you're doing an angioplasty, lower extremities for an aneurysm, for a pseudoaneurysm, then you would want this code instead of the lower extremity angio component or packaged codes. But really the emphasis is on that the new dialysis codes include the angio, and we do not use 37246 through 37249 for any angioplasty within the dialysis circuit. We see a lot of changes within 2017 to continue, hit the wrong button, to be able to continue to see what is included with guidance and what is included without guidance. The important thing here is if you're doing these spinal injections, it clearly says without imaging guidance and then a separate code with. But then read the rest of the sentence. It says IE, fluoroscopy, and CT. Now there's a difference between IE and EG. IE is fluoro and CT. EG is, for example. The AMA's intent here is that if you use fluoro or CT, that is guidance. If you, for whatever reason, are performing these injections, say, under an ultrasound guidance, then the perception is that the ultrasound guidance does not provide the same visual clarity, does not offer the same guidance that CT or fluoro would. If you use ultrasound guidance for the injection of these spinal procedures, they are to be reported as if it is done without guidance. So the only way you can bill a 21, a 23, a 25, or a 27 is if you have documentation of fluoro or CT. So on this slide in your handout, you've got more of a checklist. If ultrasound guidance is used, report it as without. Infusion, which if I back up one, notice that the infusion starts with 62324, continuous infusion. The definition of continuous infusion means that that procedure lasts more than 1 calendar day. So it's not an administration of a drug during a procedure. The patient actually leaves the suite with that infusion cath in place, and it is exactly what it says, prolonged. And so there are some guidelines here for those as well. In addition, additional guidelines related to fluoro guidance and other guidance specific to these codes. Just anticipate it. We get new codes, we get new guidelines, and there's a lot of emphasis now on this being in a single calendar day versus over multiple days. The timing on it matters as well. The other takeaway with these specific spinal procedures is those of you who work with these know you can enter a body at one area but actually be imaging or actually be treating another level. So pay close attention to the second bullet. My code choice is based on the region at which the needle or catheter entered the body. A decision point, which means it's a documentation point. So we want to make sure that the physicians and the providers performing these services are aware of that. And the code should only be reported once, even if that tip moves into a different region, because again, I'm reporting it based on where it started, not necessarily where it went. Those of you who are coming from percutaneous procedures know that it's a little backwards, because in like selective access, we're used to paying attention to where that catheter stopped, not so much where the catheter started. Throughout the CPT book, they've really, in 2017, spent a lot of time on definitions. What is the definition of indirect visualization? What's the definition of direct visualization? And so again, if I can just encourage you to take some time and circle back with the very specific, the guidelines. For example, open. It has to be continuous direct visualization of the spine. Percutaneous is going to be image guided. And there is a small typo in the CPT book. It says computer versus computed, and that's one of them that we've picked up from the technical corrections, but those things we would sort of expect in the time frame that they have. But direct visualization, it can be by eye, it can be by loops, microscope, endoscope, but there is a big difference between the indirect and the direct. So make sure that the techniques match the documentation, and make sure that the documentation includes a technique such that we can assign the appropriate codes. All surgical services are presumed to be open unless it is otherwise specifically designated within the code. Okay, moving on to radiology. And radiology, honestly, a lot of the changes in radiology, again, are a domino effect. If you think about all of the surgery codes that we just bundled the imaging into, well, then we had to go through and clean up all of the imaging codes to ensure that they were not built on top of a code that already has it. So I really want to focus on just the true changes within the radiology section. And the first one is a category, a G code, which we know is a HCPCS and created by Medicare, has been replaced with a Category 1 code for a AAA screening. So 76706 for the abdominal aortic aneurysm screening, emphasis on that word screening. Make sure that you're changing from the G code to the 7 code, and again, that is a positive move because a lot of private insurance companies really struggle in using those HCPCS codes. If you are doing any breast imaging, this is a section that's going to cause a little bit of angst, at least Q1, if not for all of 2017. And some of you are looking at the code going, how hard can it be? All they did was bundle CAD into the mammo codes. We all know that if two CPT codes are routinely reported, which means usually more than 50 or 75% of the time, Code 1 and Code 2 are built together. The AMA graciously bundles them together and gives us one code. Much easier for processing. Not necessarily for reimbursement, but definitely for processing. And that's all they've done. CAD is really standard of care. And so instead of having a separate line item for CAD, it's been bundled into 77065, 66, 67. Pretty straightforward. Unless you're Medicare. So these are CPT codes. They will be accepted by private carriers across the board. It's part of the HIPAA code set. But Medicare has announced that they are unable to process the change required in the RVUs to bundle that CAD into these 3 new codes. So what Medicare has decided to do, they're going to keep the G codes that they've used, but they're going to update it to the new descriptions. So you're actually going to have existing codes with a new description, and you're going to have new codes with the new description. So what does that mean to a Medicare Advantage plan? What does that mean to any of the smaller Medicaid, supplemental type plans? I don't know. It's going to be a little bit of a mix, especially if you have any crossover claims. Notice that all of them say CAD when performed. So if you do not use CAD, simply use the same code. Don't modify it. And stay on top of communication from Medicare. As we merge through 2017, they promise they'll accept the new codes by 18. It would be really nice if they accepted them somewhere mid-year. Just because they updated the CAD does not mean they changed any of the TOMO. And so the notes have been modified a little bit to make sure that the TOMO codes are consistent with the new mammo codes, but they have not changed and they have not bundled any of the TOMO codes. Just make sure you're not mixing diagnostic TOMO with screening mammos. And if you're using the electrical impedance breast scan, it is still an unlisted procedure code. This deletion was very interesting, curiouser, for those of you who are familiar with that reference. 93965 for NIPS, it's been deleted. And that's not earth-shattering. What's earth-shattering is why it was deleted. And all of the medical societies said that this is an obsolete service, that it really is not done anymore. And when that announcement was made, there were some, little eyes going back and forth thinking, don't we still bill that? It's possible. The challenge with it is the intent of the code is that these were studies performed on equipment separate and distinct from a duplex ultrasound imager. And that's not how we practice. And so if I'm a practice and in 2016 I ever billed this 93965, that may be one of my choices for auditing throughout this year, to make sure that it was in fact using equipment that was separate and distinct. And if the specialty societies are saying, you know what, we really don't do this that much anymore, then it's not something that should be on my high frequency list. Radiation oncology has a lot of nuances to it that are very specific to that area, and so I'm going to default that as I have done in years past, and I'm going to say reach out for an expert. Now granted, we do have one on staff if you need one, but there is usually such a limited target audience for those that I really want to spend the time in lab and in medicine that impacts more of us. So let's move on to the lab services. There are 15, literally 15 pages within your CPT book that offer descriptions, that offer coding guidance, that offer, acronyms and information related to molecular pathology gene reporting. That's interesting because it definitely shows a trend in our medical culture, but it also says if these are services that you're rendering, grab a very large bag of chips, soda, and sit down with the book, because in an hour webinar, we are so not covering every one of those details. The detail that's going to affect more on the line today are the drug screenings. And the drug screening codes have been divided into 3 sections, whether it's therapeutic, whether it's presumptive, or whether it's definitive. And so you want to take a look at those new codes. They are also coming with 3 full pages and definitions and acronyms. Just make sure that you check those page drug class listings to make sure you're getting the right code assignment, because you're really only coding, for example, if I use the presumptive drug screening, you're only going to be reporting one of these per date of service. So we really have to make sure we're not unbundling here. There's an 80,000 code for almost every drug screen out there individually. But it's also, when they're being done specifically in this intent, it's a group. All drugs, all classes performed by a respective methodology per date of service. So the real question is it direct optical observation? Was it instrument assisted? Or did you have the chemistry analyzers? And so that's the key takeaway on those. Now, as we mentioned in the opening, moderate sedation is obviously a key change within the medicine section, but we have a couple others before that. Each year we can expect a change in the flu vaccine codes. Each year we get a different cocktail, if I can say that, to fight the flu vaccine, and so each year we get a new code to help us fight that. And this is a challenge for those of you in primary care, because boy, this is an area that does change every single year. Psychotherapy codes have been minorly tweaked to simply remove the verbiage and or family member. Time limits have been added to a couple of the codes, but for overall, the psychotherapy codes were not significantly revised for 2017. Neither were the ophthalmology codes. The fluorescein angio has been revised to simply say whether it's unilateral or bilateral, but there really weren't any significant section overhauls within ophthalmology. Cardiovascular recognized 3 new codes specifically for valve repairs, percutaneous catheter closures, And with cardiology, as we've seen in years past, it's not so much that we get a new code or that they change the code description. But cardiology, like a lot of the surgical, come with pages and paragraphs of instructions. And so make sure that with the new codes, we are not unbundling any specific services. That phrase, when performed, is key, because if you don't do it, here's your code. If you still perform that transapical heart cath, this is your code. And so that kind of language is very important, and if you're working with an online code manager, make sure that you still have access to all of the notes and all of the guidelines that go with those codes. Those in oncology, I'm pretty excited about the new code 96377 for the on-body injector. Now, I'm not trying to advertise for this shot of Neulasta, but it's definitely one example that a lot of you in oncology will recognize. It allows for the drug to be administered after the patient has left the next day. It prevents an additional office visit. It's definitely in the best interest of the patient, and we've really not had a designated code for that up to this point. Physical medicine and rehab. This section was overhauled fairly well for 2017, and so there are a couple of cautions. It may seem similar. It may look like, it may feel like the E&M section, but it's not. Just because it quacks like a duck, walks like a duck, it might be a goose. So don't use the terms from your E&M language with the physical medicine and rehab section, and you can see it immediately. The physical rehab therapy, the documentation now has a history, an exam, and a clinical decision-making component. There are new codes, and then there is one generic reevaluation code. So the details of that history and the exam and the decision-making factor in on the initial code. And on that initial code, the level of the evaluation is reported and based on the depth or the extent of the evaluation. This is where it starts to look like and feel like an E&M with body regions and body systems, but it's not. These are very specific to the physical therapy definitions. The same thing with the review of body systems. Do not confuse this review of systems with the review of systems for the office visits. The definitions and classifications are very distinct. The end of the day, though, you're seeing a very similar feel. There is a code that's based very specifically on the level of history, exam, clinical decision-making, and, if relevant, time. There's 3 primary codes, or 3 initial codes, and then the 97164 that is a re-evaluation. Occupational therapy follows the exact same type of overhaul. There is specific definitions that relate to the various components, and then if that assessment includes 1 deficit or 5 or more, if the clinical decision-making is moderate versus low, it has the look and feel of an E&M. So it's very easy to understand how we could confuse the two or how we could try to overlay. They have time components to them, but we have to be very careful. And if you find yourself in a situation where you are reporting both E&M and these physical medicine codes, then it's going to take a little bit of extra review, extra caution as you move through these. Now, there's some additional changes coming through from athletic training, and the National Athletic Trainers Association worked very closely with the AMA to come up with codes for athletic training evaluation codes. The 97005 is going to be split into 3 codes, and this 9706 is basically going to look the same, but it will have a time element to keep it consistent with the other codes within that range. So it too has the history exam, its clinical decision making, and again it has its own definitions when it comes to body regions versus structures versus medical decision making. The review of systems for these athletic training codes are very specific, and then this is where it looks like our standard E&M. And that's where we have to be very careful that you're applying the correct section guidelines to to that section of codes. And don't try to carry guidelines from one section into another. Even though it looks the same, feels the same, it is not the same from a fundamental description basis. There's been one small change to the wound care. They simply added larval therapy. This is not the code we want to go into great detail just before lunch, but be aware that that has been added. I think the long-awaited topic for today is the moderate sedation, and we know that all of the bullseyes have been removed, and so 9914345, instead of updating the description, they decided simply to just delete them, start over. So you'll notice a couple of similar characteristics and then a key distinction. 99151 is when the services are by the same physician. That should look familiar to you. But notice that it's an initial 15 minutes, not an initial 30. And that's a huge change from the old setup. If it's done by another physician, then that feels exactly the same. But again, the time limit is on 15 minutes, not on the old 30. Because it has been revamped, the AMA took the time to print or to create quite extensive guidelines to sort of remind us of when we use moderate sedation and when we don't. What is the definition of an independent trained observer? And they've taken the time to really break out pre, post, and intra work to ensure that we are counting those minutes appropriately. We count the time based on the administration of the sedating agent, and it ends when that provider stops the face-to-face. So my independent observer is spending a lot of pre and post time. That does not count into the minutes that I actually report with. Okay, those are the highlights for the Category 1 codes. I know we've got just a couple minutes as we're coming up to the top of the hour. But if you'll just hang on, I want to highlight some of the Category 3 codes. As a reminder, these are considered the temporary or the Pinocchio codes that want to grow up and be real codes, but they're not quite there yet. As we have incorporated certain codes, they've grown up and become Category 1 codes, then obviously the Category 3 codes are deleted. There is a significant number of codes. I don't remember if this section has 10 and the other one has 14 or vice versa, but there's a good chunk of codes specifically for a new technique, new process, cardiac modulation or CCM, very patient-specific, diagnosis-specific. The format and the reason why there are so many codes is that they have set them up to be very similar to all of the other cardiac device monitoring codes. So there's the generators, there's the electrodes, there's the removals, the removal of the generator, the pocket. All of those are going to have individual codes, and they are temporary, and so they may or may not be reimbursed by the payers, but it is the most specific code. They also have their own evaluation codes, which again is why there are so many of them. There's a brand new myocardial contrast perfusion echo that is listed in addition to the primary procedure. We've got a new code for gene coding, and you could expect to see more and more of these as that type of medicine evolves and becomes more popular. There is a absorbable spacer for a biodegradable material, including the imaging guidance with an 0438T. We have 4 new ablation codes, and you can see that as that technology becomes more and more prevalent, then obviously we need the codes to be able to report that. There's a new code for spectral analysis, specifically of prostate tissue. And then the final block that is most significant from a quantity standpoint, again, is specific to cardiology with a counterpulsation ventricular assist program. And again, it's following the exact same pattern of codes for any other device: an insertion, a removal, relocation, and then if we're programming that device. Jill, that brings us back up to the top of the hour, and I think that that's, a lot of information at the, in a 60-minute window, but I hope people can at least take away. I need to circle back and look at this this, and this. Or for some of you, if I'm, in ophthalmology, I am smiling broadly, thinking I have scathed a lot of the significant changes this year, aside from moderate sedation. But if you have any questions, I think we're open to take those or to handle them. Jill, I'll turn it back to you.
Well, thank you, Karna. That was just another incredible webinar. We do have, I believe, time for one question. What are the documentation requirements for moderate sedation, and is it true it can now be billed with all procedures?
Well, that's a really good question, and I'm glad that you brought that up, because there is a caveat, as there always is. If we're going to do moderate sedation, I'm going to answer it backwards. Remember that we have CPT rules, and the CPT rules say that moderate sedation is now separate from the procedures. Do not forget the CCI edits, because as Q1 CCI edits are being released, we are seeing where moderate sedation is still being bundled according to the CCI guidelines, which applies to Medicare. And if you are an organization that uses Medicare across the board, then those are some considerations you need to take into, to think about as you move forward into 2017. CPT says moderate sedation is now separately reported when it's used. CCI edits say, oh, wait a minute, hold on. Medicare is going to bundle it in certain circumstances. So you're going to watch your CCI edits. As far as the minimum documentation, think about the description of the code. And this is true with anything, so I'm glad that the question got raised. Moderate sedation is a time-based code. Obviously, time is going to need to be documented. If your organization documents from 10:01 to 10:07, or your organization documents 6 minutes, that's sort of an organizational decision, or your experience with the payer. But if time is a component, time has to be documented. There is a code specifically for the same physician or a separate physician, so that's obviously a documentation point. The guidelines also require a qualified trained observer, and so somewhere in there I have got to read that moderate sedation was provided by and a qualified independent trained observer, and whether they use that statement or whether you put in the actual name is up to your organization. But the easiest way to say what is the minimum documentation is to look at the code. And if there is any phrase or any information that makes one code distinct from another code, number of minutes, same physician, different physician, then those are obviously things that have to be documented. I think the challenge that we're going to run into with moderate sedation moving forward is we've had so many years it didn't really matter from a coding perspective that coders have stopped looking, which means physicians have stopped documenting. So we're going to have an opportunity, especially Q1, to sort of strengthen some documentation. The details have always been in the medical record because they're on the moderate sedation nursing notes. We need them in the report of the reporting physician as well. And so how to merge that, how to bring that in, those are going to be some of the challenges for 2017. But thank you for helping me clarify that a little bit.
Well, thank you very much, Karna. If you want to go ahead and put your contact information back on the screen, please use her contact information there for further questions. If you send them to us, we will forward them on to her. Thank you again for joining us. You can register for our 2017 webinar series and also request a demo of our compliance solution on our website at 1sthcc.com, or you can call us at 888-543-4778. Your Paycom CEU certificate will be emailed automatically to you. And Coding Strategies does have another webinar tomorrow with Melody Malayak, President of Coding Strategies, and she will do an update on 2017 coding and compliance for radiology. So thank you, Karna, and have a great day.
Thank you as well.